Yes, I have no conflicts of interest, but I would like to disclose that maybe you'll find the talk a little bit provocative, and also at the same time the topic in itself is very broad. I think we learned many things since the Berlin definition was published. Way before COVID and through COVID and after COVID, we are still learning a lot. So I will focus on some aspects which to me could be especially relevant if we would decide to create a new, to revise the definition of ARDS. So first of all, what is a definition? The definition of definition is to state the meaning of something, or, which I think is more pertinent to our task today, to explain or identify the nature or the essential qualities of. And I think this is very important to keep in mind. The definition defines the essential qualities of ARDS in this case, and I will come back to this later on. So after the Berlin definition was published, and the Berlin definition already tried to address some of the limitations of the previous American-European Consensus Conference. There have been a number of criticism and challenges put forth to the Berlin definition, and I could spend my entire talk in saying what are the limitations of the current ARDS definition. And the main one, I think, is that it's a syndrome, it's not a disease, so we are lumping together patients, and my mentor, Antonio Pesenti, always says from malaria to pancreatitis under the same umbrella. We look mainly as mortality as our benchmark, if you wish, to measure the reliability, the validity of the definition. And of course, in ICU patients, mortality is affected by several other factors. PF ratio in itself is very dependent on the condition you measure it, let alone the interpretation of chest X-ray, and it is not always applicable. I could go on for, as I say, the entire 20 minutes speaking about this, but as we say in Milan, a critica in buntuc. Everybody is good at criticizing, so I'll try to say how we can maybe improve. So in regard to the last point, the fact, and that it is not sensitive or specific to diffuse alveolar damage. So in regard to, because this is also important as we will see, in regard to the last point that it is not always applicable, an attempt, I think it was a great work, was made by Dr. Riviello, Chiviri, and colleagues who developed the so-called Kigali definition of ARDS. So they basically said, well, in some situations, especially in lower resources situation, but we've learned that during COVID or during other situations, lower resource can be everywhere. We have challenges in applying the Berlin definition as it is. And so the idea was, let us phrase it in a way that it is applicable to a broader context. But as you see, more or less, the ingredients of the Berlin definition are the same. There is the timing, which has to be acute, the oxygenation, SpO2 FiO2 instead of PaO2 FiO2, which makes very good sense, and I think we can already use that in our hospitals. They let out the PEEP requirement and substitute the chest imaging with ultrasound, which in fact, under some aspects, could be even better than chest X-ray because of the clear possibility to separate atelectasis or lung infiltrates from pleural effusion, which even myself can recognize on lung ultrasound, and the origin of edema, excluding the cardiac origin. So I personally, and I'm not anybody to criticize here, but what leaves me a little bit more concerned about this is the lack of PEEP requirement of this definition. It was the case, in fact, in the American-European Consensus Conference definition, based on the argument that mechanical ventilators are scarce, which is true. At the same time, we know it's possible to deliver PEEP even without a mechanical ventilator. Plus, I think there are more and more studies, I will go back to this later, that show that, for example, this is a study we did during COVID, if we measure PF ratio under some degree of positive end expiratory pressure, the ability to stratify the patients according to the PF ratio is much, much superior than if we just measure this under standard oxygen because of correction of minimal atelectasis, I think, and we are more certain about FiO2. So personally, I believe that some degree of PEEP much improves our capability to diagnose and to stratify ARDS. In regard to timing, also this has been a rather debated issue. I would like to present one of the ancillary papers from the LungSafe study by Fabiana Madotto. First, what we've learned from the LungSafe study is that prospectively applied, the Berlin definition did work. It was able to stratify the patients according to severity and hence, in a way, to mortality. But it turned out that if you wait 24 hours and measure your PF ratio 24 hours after the beginning of the disease, you end up stratifying the patients much better, and this is especially true for the patients with severe ARDS after 24 hours from the diagnosis. So, as you see, this population is clearly separate in terms of mortality, and so this could be a population on which to target higher risk intervention like ECMO, for example. In any case, if you take the American European Consensus Conference definition, if you take the Berlin definition, Kigali definition, more or less, they all go back to what Aschbach had described in 1967. Dyspnea, tachypnea, cyanosis, because they didn't have SpO2, so they just had their eyes, but this is hypoxemia, refractory to oxygen therapy, which means requiring positive pressure ventilation, loss of lung compliance, which I believe it's important to measure, and diffuse alveolar infiltration seen on chest X-ray. So I think we pretty much have a definition of ARDS because we explain, or it explains or identifies the essential qualities of something: acute, hypoxemic, hard to breathe, diffuse infiltrates. So why, when it comes to the issue of Berlin definition, we feel like we are lost in a maze, and honestly, we keep talking about it because we can't find the bundle in my opinion, not just in my opinion. And the reason to me is that what we have been looking for 50 years, and we read it very well, not because I say it, but because it's written in the Berlin definition of ARDS, we have always looked for diffuse alveolar damage, meaning edema, inflammation, hyaline membranes, or hemorrhage. So the attempt was to make a definition of ARDS based on clinical criteria that would identify patients with this type of lung injury. Except, and again, this is a point where I show only one study, I could show many, many more. We all know that by clinical criteria, whether you take the American European, you take the Berlin definition is a little bit better, but still our capability to realize, to identify diffuse alveolar damage is really poor. And so this is the first provocation I launched to you. If we believe ARDS is diffuse alveolar damage, I think we should give up on the idea of diagnosing ARDS at the bedside. Okay, so I was given this talk recently and yes, of course, there are points, there are some elements that have to do with the Berlin definition, with our definition. So patients with diffuse alveolar damage have lower PF ratio, higher peak inspiratory pressure, but still the sensitivity is not enough. And I was given this talk last week, which was similar. From Berlin to Kigali, we're next. So if we consider we start from Berlin, we move to Kigali, and if we travel in the same direction, Same distance, we end up here, which you might think there's nothing in there, but if you zoom on Google Maps, you'll find, in fact, that there is an island. There's a Marion Island. So a next definition, I think, should be called the Marion Island definition of something. Should we move something in some other direction rather than southbound? Maybe there are other directions. And so I think one possibility would be just to aggregate our patients under a broad clinical aspect, which is what Ashbach defined. Patients with severe hypoxemia requiring positive pressure ventilation, more or less like this, with an acute onset. Or we could move in a totally other direction, which is go and assess what I'm an anesthesiologist, so I'm a little bit gross, but what I call a biological mechanism, those things that John and Caroline know very well. So basically focus on biomarkers, specific biomarkers for specific processes. So what happens if we go in the first direction and we aggregate patients with hypoxic disease requiring positive pressure ventilation? This is a piece taken by 3 super world top experts of the disease, Guerin, Thompson, and Roy Brower. And shortly, if a patient with ARDS requires mechanical ventilation, substantial risk of VILI because of inflammation, the volume of aerated lung is reduced, we recommend using a lung protective approach with an initial tidal volume of blah, blah, blah. And you will all be like, so what? Well, they're not talking about ARDS. They are talking about 10 diseases that look like ARDS. But their recommendation is to manage them exactly as we will manage an ARDS. From a ventilator and, to me, supportive therapy aspects. But if we do not consider these patients as having ARDS, for example, it would be a trouble to enroll them in a study on lung protective ventilation. And another very nice study was led by Tai Pham on patients who wisely were enrolled in the lung safe study who did not have necessarily ARDS, but who had acute hypoxemic respiratory failure. And specifically, I would focus on those patients. I mean, the paper was pretty much focused on patients with a unilateral disease. So, no, this patient does not have ARDS. The patient has unilateral pneumonia. So it's not ARDS, it's another thing. It's a unilateral pneumonia. So what did Tai found? First of all, those patients here, you see them in the middle with a unilateral infiltrate that were intubated and developed, some of them developed ARDS, which basically means the disease became bilateral. These patients had some risk factors, including peak inspiratory pressure. And so basically what we do in ARDS is also good for unilateral pneumonia. Moreover, if we compare patients with unilateral infiltrate and bilateral infiltrates, no wonder bilateral infiltrates is more severe, and so these patients die more. But if we consider another situation, patients with 2 quadrants involved, either bilateral, so these patients have ARDS, or unilateral, so this patient does not have ARDS, well, Tai didn't find much of a difference in the outcome of these patients, and no difference at all, despite, I would say, a huge statistical power in the way we stratify these patients, we manage these patients. So are we sure that, again, in a trial on lung protective ventilation, we do not want to enroll a unilateral disease? Now, don't fall out of the chairs, but I will go to patients with heart failure. This is the association between driving pressure in patients with heart failure and outcome. It has this shape. This is from the lung safe, ARDS. I would say that this two curves look quite similar to me, don't they? And for the sake of time, I will have to skip this slide, but to tell you that normal lung react to a PEEP change similarly to what an ARDS lung does. My time is almost over. So on the West, I'll be much more fast because then we have two excellent talks by Dr. Pellegrini and Caroline. And basically what the groundbreaking work that came from Caroline and her group was to stratify the patients according to subphenotypes, all patients with a clinical diagnosis of ARDS, and showing that, for example, the response to the treatment is very different if patient has a hypo or hyperinflammatory phenotype. And there are also other ways to, other markers we could look to. For example, we need to treat fibrosis. Well, let's look at a biomarker of fibrosis, not at the broad definition. So I'll finish with my proposal for the Marion Island definition of ARDS. So, first of all, we get rid of the term ARDS because it is too emotional, okay? ARDS has been there, but we have to find another name, and I think acute hypoxemic respiratory failure is fine. Then we have a layer, which is mild, moderate, and severe, perhaps with some adjustment in PF ratio, the time to wait. Then we have all the etiologies, and yes, it's not blasphemy. We have different etiologies. We have cardiac, septic, and even autoimmune. And then finally, we have an inflammatory layer. So the patient is hyper or hypoinflammatory. So it's not all or nothing. It's not just mild, moderate, severe, but it's a sort of a TNM-like system. And how would we use this definition? Of course, I'm not suggesting that we enroll all patients with acute hypoxemic respiratory failure and lump them all together. But, for example, we have a study on non-invasive ventilation. Okay, so we focus on patients with mild ARDS and a hypoinflammatory phenotype, and vice versa if we have a study on an anti-inflammatory drug. So going to my conclusion, I think that if ARDS is diffuse alveolar damage, I think after 50 years, the idea of diagnosing it with X-ray, PF ratio, blah, 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 didn't work. I think we might reappraise the concept of acute hypoxemic respiratory failure for what ventilation and supportive therapy has to do. And finally, if we want to target a given process, we have to have a biomarker that tells us that the process is there so that we can target it. And with this, I thank you very much for your attention.
Thanks very much, Giacomo. This is open for questions. So I have one question. It's not really a question, it's more a comment. But finally, when the average person on the street knows what ARDS is, you want to get rid of it?
You know, let's call it ARDS too, but the problem is that when it comes to ARDS, everybody seems very, sensitive on what ARDS should be. So the idea is to change the name so we make sure we don't confuse older and newer definition.
Any questions?
I mean, we can keep the name if you want.
Okay.
Thank you.
Thank you, Giacomo.